Yeah. So, as I am presenting my talk, I do not have any conflict of interest or I have nothing to disclose about what I am going to discuss in this lecture. And as we all understand, depression is a common mental disorder. Its prevalence is very, very high, and if you look at any estimates, the lifetime prevalence of depression is about 1 in every 5 person will develop depression, and at any given time the point prevalence of depression is about 5%. So that means it's a very common disorder which requires attention, and it is seen across all age groups, starting from children, adolescent, adult, elderly, and very, very elderly. And it is one of the most common disorder which is also seen in people with various medical illnesses, and is associated with high level of disability, and it is one of the most common cause of morbidity and disability across the globe at present. It is also associated with high rates of suicide, which is a burning problem in today's world, and unfortunately what we know is it is often under-recognized, untreated, and if at all it is treated, it is inappropriately treated. As we try to understand depression, it's a heterogeneous condition which has lot of symptoms which could be characterized as emotional symptoms, neurocognitive symptoms, and the physical symptoms. Basically, we need to understand it's not that depression doesn't manifest same in every person, and as the ICD-11 tries to define them, we define symptoms of depression now in 3 basic clusters as the affective cluster, the cognitive behavioral cluster, and the neurocognitive cluster. The affective cluster basically includes the depressed mood in the anhedonia, and the cognitive behavioral cluster will include the poor attention, concentration, and very depressive cognition, and the neurovegetative includes the disturbance in the biofunction and the psychomotor retardation and reduced energy or the fatigue. And when we look at the whole spectrum of depression, again we will understand that it varies across the severity, or we can understand depression ranging from major depression to mild depression, dysthymia, or unipolar, bipolar, depending on the presence of hypomania, mania, depending on the treatment response as treatment-resistant depression, difficult to treat depression, and various specifiers as defined by DSM-5 as psychotic depression, melancholic depression, depression with atypical features, and so on. So basically what I just want to emphasize to everybody that depression is a heterogeneous condition. Then we try to look at the comorbidity patterns of patients with depression. So about 1/3 of the people will have comorbid substance use or any other psychiatric disorder, which can include something like phobias, generalized anxiety disorders, PTSD, OCD, and so on. And in terms of its prevalence in various the physical health conditions, the prevalence of depression again varies from, let's say, from 10% to about 70-80%, depending on how you are assessing depression and what is the cutoff which you are taking to label somebody as having depression. And in terms of etiology, again, we need to understand that there are different hypotheses which can include the biological, the psychological, the social, or the somatic risk factors or the etiologies for understanding depression. So, and when we look at all this, we try to understand that depression is a heterogeneous condition. So when we try to answer this question, are all patients of depression the same? The simplest answer is no. So this is one thing which we need to understand as physicians, as clinicians, which we all try to treat depression or understand depression, and we try to tell people that it's a simple depression, nothing big deal, but it's not like that. Depression has a lot of different implications as we try to understand the clinical picture. So then are all the patients with a particular type of depression the same? Again, the answer is no. Basic reason is that because most of the antidepressants are metabolized through liver, the CYP450 system, and that's where, depending on the metabolizer, we can have something like ultra rapid metabolizers or the normal metabolizers or intermediate metabolizers or the poor metabolizers. So this will again determine the serum antidepressant levels when you are using antidepressant, and this will determine the treatment response. So although if we take a subgroup of patients of depression who are similar in their clinical characteristics and other aspects, still the response to treatment may be different. So what we need to understand that one size is not going to fit for all, means you cannot select or predict using a particular depression for a particular type of depression or a particular type of patient. So this is where we need to be very clear. So if you just again try to answer the second question, are all patients with a particular type of depression the same? The answer is again no. So then how does clinician manage patients with depression? So as I say that clinicians often have a dilemma which antidepressant to choose, which one to give to a particular patient. And ultimately there is a so-called, as we try to understand what are the factors which determine the selection of antidepressants. So it is a SAD assessed to drugs, that are the factors like severity of depression, adverse effect of the medication, the dosing schedule, the OD or the BD schedule, the age of the patient, the comorbidity patterns, the cost of treatment, the effectiveness of antidepressant in particular comorbid conditions, the symptom profile, safety in the higher doses because the patient can be suicidal, drug interaction because if the patient has depression in the background of a medical comorbidity, treatment resistance, and how much they understand with respect to using antidepressant and what they don't understand, and the gender will influence the selection of the antidepressant. Then let's try to understand what are the so-called unmet needs of current antidepressant. Unfortunately, whatever antidepressant we have in the market at this present, like they have a lag period of action about 2 to 3 weeks, maybe 4 weeks, which again people don't understand and just try to, without understanding that, either give patient polypharmacy or give higher doses. That is actually detrimental for the patient. Then there are a lot of sexual side effects of antidepressant which are bothersome for most of the people and often are the step limiting factors in patients to continue their medication in long run, and that leads to poor medication adherence. And sudden stoppage of certain antidepressants can lead to withdrawal symptoms, and often many patients continue to have residual depressive symptoms. That means although they may respond to an antidepressant, but they may not achieve full remission or total recovery from the depression. So what will determine how do we go about antidepressants? So it is basically the efficacy, the withdrawal or the discontinuation, and the tolerability. So let's see what data we have to compare various antidepressants. So this is one of the biggest so-called meta-analysis and network meta-analysis in understanding various antidepressants across the globe, and this meta-analysis has data of more than 1 lakh people, and out of which about 26,000 were on placebo and more than 75,000 were on antidepressant, and it included data of most of the published and unpublished studies across the globe. That's the biggest data bank which we have at this moment for understanding the various antidepressants, and let's see how does it different antidepressant compared to. So when we look at a comparison of various antidepressants compared to placebo, in terms of efficacy, you will see that the antidepressant like amitriptyline, mirtazapine, duloxetine, venlafaxine do much better than other antidepressants, with escitalopram, sertraline somewhere in the middle range. And when the efficacy is understood as response, present or absent, and when we look at as a continuous course of on the various depression scale, again the amitriptyline, duloxetine, mirtazapine and venlafaxine comes at a much higher level, and escitalopram is at somewhere in the middle level. So that is where we need to understand in terms of efficacy, the more dirtier the drug, or the drug which is acting on more than one receptor, performs better than drugs acting on the single receptor. However, we need to talk about the acceptability, that is the tolerability, and whether these patients are going to take this medication or dropout rates. You will see that the best tolerable drug is agomelatine, fluoxetine, escitalopram, and the good drug like clomipramine goes down the ladder, totally down. And in terms of dropout due to the side effects, again agomelatine is at the top of the list, followed by vortioxetine, milnacipran, desvenlafaxine, and other drugs which come closer are something like escitalopram, fluoxetine, citalopram and sertraline. But again, the drugs like clomipramine, amitriptyline, trazodone, all the classical tricyclics or tetracyclic antidepressants are very, very poorly tolerated by the patients. So that is where we need to understand, although these may be efficacious, but these are not tolerated by the patient. In terms of again remission rates, again you see that remission rates are again very high with drugs like amitriptyline, duloxetine, nefazodone, venlafaxine, with escitalopram somewhere close to them, but not at the top of the list. So what does this evidence suggest to us? Because all this evidence is in terms of comparison of drugs to the placebo, but that does not guide us which one to choose, because by comparison with placebo, maybe it will not give us the best answer. So let's look at the comparison of various antidepressants head to head. And here if you see the response rate the response rate is highest with vortioxetine, bupropion and escitalopram. These are at the top level, and in the continuous variable as in terms of efficacy outcome, again vortioxetine, amitriptyline, escitalopram figure among the top three. Escitalopram is one of the most commonly prescribed antidepressant across the globe at this moment, so that's where we need to understand. In terms of response rate, head to head, it performs much better than various other antidepressants. And dropout rates are again very low with drugs like vortioxetine, agametriptyline and escitalopram and sertraline in terms of either due to any particular reason or side effects. So that means these drugs are also well tolerated. And in terms of remission rates, again bupropion, vortioxetine, escitalopram and duloxetine top the list. So if you take all these factors into account and try to compare various antidepressants, you will see that at the top you will see drugs like vortioxetine, escitalopram and bupropion when we look at the combination of efficacy and tolerability. So these are three drugs which perform much better than others, and when we talk about the cost issue, maybe escitalopram performs much better than any of these antidepressants. So besides the efficacy in these short-term trials, let us also try to understand the other tolerability factors which influence selection of antidepressants, and this includes medication adherence, other short-term and long-term outcomes, and morbidity and mortality data. So basically the safety and tolerability data becomes very, very important, and again this is where we need to understand the various adverse effects which are possibly not often brought up so openly by various drug trials, but can have influence on the outcome or the tolerance of the patient or the medication adherence in long run. And what we see here, that the SSRIs and various other drugs have a lot of sexual side effects in the form of somnolence, insomnia and nausea, which can be very difficult in the beginning. And if you look at drugs here, only mirtazapine would perform slightly better. Mirtazapine and bupropion have side effects, sexual side effects, which are much lower compared to others. So this may be the preferred drugs, but other side effects may be there. Like with mirtazapine, you see a lot of weight gain. It leads to highest weight gain. Weight gain may be lowest with something like bupropion and nefazodone. And there are other rare side effects like GI bleeding, seizures, atypical, so-called atopic reactions, or their liver dysfunction and so on, or seizures and so on. So all these risk factors, all these side effects become important in patients who have physical comorbidities, and there the selection of antidepressant is again guided by these rare side effects rather than only efficacy or the short-term tolerability, because we do not want the so-called underlying physical illness to worsen. So these factors again become very, very important. So from antidepressant perspective, if we try to answer the third question, are all antidepressants the same? The answer is no. So what we need to understand, that if all antidepressants are also not the same, that we have answered all the three questions, that all all patients with depression are not same, and if we look at all patients with a particular type of depression, they are not the same, and all antidepressants are not the same. So this is where we need to learn the so-called puzzle how to use antidepressant. So what we need to understand, that are we looking for an antidepressant for a patient, or are we looking for a patient for a particular antidepressant? That's the question which we should be asking ourselves before we start thinking about prescribing an antidepressant for any particular patient whom we are considering to use antidepressant. So what are the factors which determine the use selection of antidepressant? It is the overall efficacy, the symptom specificity should be kept in mind, the comorbidity specificity should be kept in mind, and the adverse effects should be kept in mind. So something like a patient with atypical depression, MAO inhibitors will be better than TCAs. For severe depression, drugs like venlafaxine, SSRIs, venlafaxine may be better than SSRI. And for cognitive symptoms, now we have some data emerging for the presence of cognitive symptoms, that cognitive symptoms respond better to the vortioxetine. And in terms of the psychiatric comorbidity, most of the data is actually available for SSRIs, and SSRIs are also effective in other conditions like anorexia nervosa, bulimia, and other conditions like OCD, panic disorder, PTSD, and the social anxiety disorders. So we need to understand that if you are looking for a patient, remember the comorbidity profile, that is the psychiatric comorbidity profile that can determine the selection of antidepressants. Similarly, the physical comorbidity, again, a lot of data is there for SSRI, but for the cardiac patient, we have some data for mirtazapine, And for asthma patient, there is some data for moclobamide, and in the stroke patient, again data has emerged from mirtazapine, milnacipran, and other drugs in the recent times. So the important facts to remember are these serious side effects when we are selecting the drugs, and in patients who are having the liver damage. Safest drug could be something like citalopram or escitalopram, and drugs which should be avoided are something like nefazodone, duloxetine, venlafaxine, and egomelatin. Similarly, for skin condition, various drugs have particular different kind of skin reactions that needs to be kept in mind, and weight gain is very high with drugs like mirtazapine, paroxetine, tricyclic antidepressant, and the drugs which are considered to be more weight neutral are something like vilazodone and vortioxetine. And in terms of cardiac side effects, again, because the cardiology is totally a very broad subject, that's why we understand the different side effects of antidepressant from a cardiological perspective. Different kind of side effects have been noted. So the most troublesome is the orthostatic hypotension, which is commonly seen with the TCS, and in rare cases with the SSRIs. And with drugs like SNRI, venlafaxine, and duloxetine, there is always a chance of hypertension, so that needs to be kept in mind. And of course, the QTc prolongation with drugs like citalopram, fluoxetine, and sertraline needs to be considered. And urinary retention and urinary incontinence also becomes an issue when you're selecting an antidepressant for elderly. The other important metabolic problem, which is again commonly seen in elderly, those who are on various medications, is the hyponatremia, which is often neglected. Physicians will often end up using antidepressant in elderly in a higher dose, and this patient present to emergency with seizures, which is secondary to hyponatremia, and then the patient goes on to develop the pontine myelinosis. So these are often neglected. So that needs to be kept in mind. Similarly, SSRIs in long run can lead to osteoporosis. That needs to be kept in mind. Again, GI bleeding, again for gastroenterologist, again it's very, very important to understand when anybody comes with a GI bleeding, and it's always important to collect the history of use of antidepressants. And some of the antidepressants can also lead to the extrapyramidal side effects, and that needs to be kept in mind when these are used in the hand of the neurologist. Then the issue of sexual dysfunction is again important, and that needs to be kept in mind when you're selecting an antidepressant for young males and young females. And in terms of pregnancy, among the SSRIs, paroxetine needs to be avoided in first trimester of pregnancy because of the high risk of the congenital malformations. And in close to the delivery, antidepressants are known to be increase the risk of postpartum hemorrhage, and they can lead to withdrawal symptoms in the neonates. So these factors again becomes important in the gynecological practice. So how do we solve or how do we manage depression in patients with various conditions when we understand depression as a heterogeneous condition? So we need to take the patient specific and the drug specific factors into account while choosing antidepressant. The patient specific factors could be the patient preference, the cost issue, the past history of response to the medications or the other medication which the patient is receiving, or the patient's age, is it a young patient or the old patient, and the comorbid conditions needs to be kept in mind. And of course the gender issues, and in the drugs, the cost, side effects, efficacy needs to be kept in mind. And of course the patients who prefer to take tablets, syrup or capsules needs to be considered. And of course, because many patients of depression are suicidal, so risk of overdose should be kept in mind while selecting antidepressant. And so in a highly suicidal patient, it is always recommended that the drug should be handed over or should be handled by the family rather than the patient. So that needs to be kept in mind. So how do psychiatrists select antidepressant? That's where we need to look at. This is a study from US where the psychiatrists selected various antidepressants. The most commonly used antidepressants were escitalopram, bupropion, and sertraline, venlafaxine, and mirtazapine. And when we look at the reasons for selection of various antidepressants, we need to understand that antidepressant selection was influenced by the presence of specific symptom or the symptom profile, wish to avoid certain side effects, or presence of the comorbid medical condition or the response to a particular medication, or patient had a good response to a previous medication in the past, and the dosing pattern and the drugs samples which are available to the doctor. So these are the factors which ultimately determine the selection of the drugs rather than just talking about the efficacy. So the other factors in terms of symptom profile, if you look at the symptoms which determine the selection of drugs were anxiety, insomnia, fatigue, and so on. So these are the factors which needs to be looked at, and we should go for selection of antidepressants. So just to conclude, all patients of depression are not same, and all patients with a particular type of depression are again not same, and all antidepressants are not same. So prescription of antidepressant should be personalized, and that should be done by taking all the factors into account rather than just considering all depression as homogeneous and prescribing antidepressant blindly. Thank you.